70 years old female presented with the chief complaints of subjective loss of weight for past 3 months, generalized fatigability for past 5 days, low-grade fever for past 3 days, and one episode of gum bleeding. History of present illness, there was no history of any abdominal pain, vomiting, loose stool, or decrease in urine output. There was no history of hemoptysis, hematemesis, melena, red color urine, and a headache. There was no history of loss of appetite. There was no history of joint pain, dry eyes, dry mouth, oral ulcer, photosensitivity. So, on examination, she was found to have stable vitals. On general examination, she was found to have a petechial rashes over the chest and ecchymosis over the injection sites on the wall. Otherwise, all other systemic examination was normal. So initial basic investigation showed a hemoglobin of 14 and total WBC count of 4,100 and platelet count of 4,000. On peripheral smear, it is less than 15,000. But the LFT is within normal limit and creatinine is also within normal limit. With this syndrome complex of weight loss with the thrombocytopenia and the bleeding manifestation in elderly age, my first differential considered was malignancy. Malignancy, the most common malignancy, first differential considered hematological malignancy such as chronic lymphoid leukemia, follicular lymphoma, Hodgkin's lymphoma, plasma cell neoplasm, MDS, and myelofibrosis. But we have done bone marrow. Bone marrow showed a cellular marrow with a trilineage hematopoiesis and adequate megakaryocyte. And other non-hematological malignancies secondary to solid organ malignancies also considered. But because of in view of financial constraints, we have done limited workup such as chest X-ray, USG abdomen, and MRI. But there was no evidence of malignancy. And then in view of a short febrile 3 days history of fever and one episode of bleeding, we have considered infectious etiology also such as viral hemorrhagic fever, scrub typhus, malaria, enteric fever, and then sepsis, and then seropositive infection, H. pylori related thrombocytopenia. But all these infectious workup came negative. So at the end of this point, we consider it is a probable immunothrombocytic purpura. But in this age, in elderly age, we want to rule out. We want to look for the secondary causes of ITP. So we have done ANA, it came negative, and thyroid is within normal limit, and there was no vitamin B12 deficiency. So based on all this, we have considered the patient having a probable primary ITP. So our patient, after the biopsy report, she was started on dexamethasone. She come on the third day of dexamethasone infusion. She developed a third cranial nerve palsy with a pupillary sparring. For this, we have done considered cavernous sinus pathology and orbital apex syndrome. We have done imaging for those, but and we have ruled out also. Hence, for considering the cranial neuropathy, we have switched the dexamethasone to the prednisolone, methylprednisolone. But then she has completed 3 days of methylprednisolone. In spite of receiving prednisolone, her platelet counts are continuously persist to decline. So before coming back to our patient, I just want to highlight on the treatment of the patient non-steroid responders ITP. So whenever the patient has a ITP, if there is a bleeding and if the platelet count is less than 20,000, if there is bleeding or no bleeding, if platelet count is less than 20,000, then initial therapy you have to start as glucocorticoid. It's the preferred one. If there is an improvement, then observe and monitor the platelet count. If there is no improvement, the subsequent therapies are intravenous immunoglobulin, rituximab, or a thrombopoietin receptor antagonist, or splenectomy. So this is an article showing the older immune thrombocytopenia in older adults. So here, as like other all other ITPs, in older people also they are considering dexamethasone. But in older people, they are preferring low dose, off the dose of the dexamethasone compared to the adult population. If there is a severe bleeding, they are considering intravenous immunoglobulin on the day one itself. If there is a response, they will monitor and observe. If there is a failure or early relapse, they will consider yearly use of the thrombopoietin receptor agonist. Even if the intolerance or failure to the thrombopoietin receptor agonist, they are considering other agents, second-line agents such as rituximab or other immunosuppressive agents such as MMF, dapsone, and splenectomy. So this is the American Society Hematology 2019 guideline for immune thrombocytopenia. But here it is when the ITP is the patient is dependent on steroid for more than 3 months, then we can consider the second line agents. And that same article 2022 review, it has added a few more second line agents. Like for adults with newly diagnosed ITP, prednisolone or dexamethasone, H. pylori eradication, or intravenous immunoglobulins. In addition, they are advising, newly suggesting combination therapy also. Agents can be used in combination with steroids such as all-trans retinoic acid, mycophenolate mofetil, and TPO, thrombopoietin receptor agonist. And then if it is a thrombocytopenia is persistent more than 3 months, the other new agents they are advising in recent review article is rituximab with or without cyclophosphamide, rituximab with or without all-trans retinoic acid, danazol with or without all-trans retinoic acid, and hydroxychloroquine, and then L-thrombovac. So in our patient on 5th day of the receiving steroids, she developed a headache and vomiting, and we have done CT brain suspecting the intracranial hemorrhage. It showed a left cerebral hemorrhage with a midline shift. Immediately, in view of critical bleeding, she received platelet transfusion and anti-edema measures. In spite of all these measures, she expired. So coming the learning point from this case is there any role of prophylactic platelet transfusion in ITP? The patient platelet count, if patient is not bleeding, but the platelet count is less than 10,000, and also the patient, for this patient we have offered second line therapy on the initial second day of steroid injection itself, but the patient is not affordable. So we looked up the articles, all the literature review saying platelet transfusion in non-bleeding patients with ITP is not much helpful. In fact, it is associated with the arterial thrombosis and increase in the inpatient mortality. Prophylactic platelet transfusion is not useful in improving the survival or in preventing the bleeding in ITP patients. So my learning points are approach to secondary ITP and management of ITP steroid non-responders.
Is there any association between ITP and cranial neuropathy?
As per I say, no, sir.
Small just the process when you decide to change to be redness. What was the exact?
We thought it may be diabetes mellitus related to cranial neuropathy.
Cranial neuropathy, for which we started.
Yes.
It was not just third nerve involvement that Gabriel was saying. After that, she also developed the fourth and sixth nerve involvement, and we ruled out a cavernous sinus thrombosis structural cause. So, for a possible colossal flex syndrome for immune mediated cavernous sinus syndrome, that we could do the recommendation. So, we didn't mention that other criteria.
Thank you. The end of the clinical meeting today, we finished at 9. So, all the presentations were good. It was pretty difficult to choose the best one. But today, I will give the presentation to Shakti from the center.